Deborah Bilder is a professor in the Department of Psychiatry in the Division of Child and Adolescent Psychiatry at the University of Utah. She also holds adjunct appointments in the Departments of Pediatrics and Educational Psychology. She completed the triple board residency programs, Pediatrics, General Psychiatry, Child and Adolescent Psychiatry at the University of Utah, and maintains board certification in all three specialties. She is a clinical and research expert in autism and is the principal investigator for the Utah Registry of Autism and Developmental Disabilities and co-principal investigator for the Utah site of the Centers for Disease Control and Prevention's Autism and Developmental Disabilities Monitoring Network. She consults for pharmaceutical companies on clinical trial protocol development for drugs and biologics that target rare genetic conditions. Dr. Bilder will discuss the sources of distress, a computerized tool developed for parents and professional caregivers of children and adults with severe neurodevelopmental disabilities. Through the completion of this survey, parents and professional caregivers have the opportunity to describe what they know about the affected individual in a manner that may translate into the potential presence of one or more conditions that commonly contribute to irritability and agitation in this patient population. The sources of distress is readily available to everyone here in our Dravet community. Dr. Bilder will lead myself and a parent ambassador in a discussion about how caregiver insights illuminate underlying causes of agitation in our children and adults with Dravet syndrome.
Hi, it is so nice to get to join you all and talking about Dravet and meeting with each other and discussing experiences of being a parent or an individual with Dravet. I'm excited to be able to join you today because what I'd really like to talk about is the caregiver insights that I have learned as I've worked with families of individuals across the lifespan who have neurodevelopmental disabilities when these individuals present in crisis. And in regards, so typically when individuals present to me with neurodevelopmental disabilities in crisis, it's usually agitation. As I've gotten to know a lot of families of kids with Dravet, I don't know if agitation is the best term for it. I think more just distress. Something's different, something's off. And they realize that there's something that is really getting in their way on top of their experience of Dravet and trying to understand what that is and allowing the caregiver's understanding of that child and their health and their behaviors really translates into helping me understand what it is that you would target to help that child feel better and make better choices. And so I just have a few slides to start off with just to kind of, get us going. And then that we have parents of children with Dravet who will be joining us in this discussion as well. And so just talking about the causes of distress in children throughout adulthood as well with developmental disabilities. And then just a strategy that I've used for almost 2 decades now, developed it to understand what it is that's causing that difficulty so that when we intervene in regards to having medical interventions there for specific issues rather than just trying to chase the irritability or agitation. The sources of distress is the tool specifically that my team has developed at the University of Utah that goes through these various different protocols to understand from the parent's perspective what appears to be going on, that as a provider, which I'm a pediatrician and a child psychiatrist and a general psychiatrist, as a provider, I then know what it is I can treat. So if you think about agitation or irritability, in my world, among mental health providers, especially in working with this population, I find a lot of providers just finding themselves focused on the agitation. And I can understand certainly why that's where their focus is, and that it's most commanding of attention. And it's most disruptive in regards to the well-being and the environment that the child's able to be in, as well as the family. Yet, at the same time, when you're going to address irritability or agitation in this population, I find it's far more effective and far safer to identify what it is that's causing the agitation, because agitation just doesn't happen all by itself. We all get irritable or agitated, and there's always something that's underlying that issue. And yes, there's a nice list of different things that can contribute to these issues, like pain, sleep disturbance, seizures. Not necessarily the seizure itself that's the agitation. Actually, that's really uncommon for me to see. Rather, it's a child who is having seizures. Between their seizures, they're not getting the same quality of sleep that they need. They just are not functioning as well as they could be functioning if it weren't for those seizures. Then psychiatric disorders, which would be the appropriate target of psychiatric medications. And then, of course, social stressors and managing their world and their experiences on top of their disability. And then on occasion, I'll see inadvertently reinforced behavior. So poor choices that occur over and over again because somehow they have found the child may have figured out how to make that work for them. And then for many kids and adults who have developmental disabilities, if they're having difficulty communicating their needs and wants, this can be a source of frustration and subsequently agitation. And so as far as psychiatric disorders, I just want to say that's, as a psychiatrist, that is what I feel it's appropriate to use psychiatric meds for, but not for agitation, but rather what's going on underneath. And yet, when I work with a population of those with neurodevelopmental disabilities, it's just so important to have a couple hats on. I'm also a pediatrician, and realizing that medical stuff can lead to psychiatric stuff and vice versa. And it's all one person. And trying to think of that individual and that child as just one person. But when someone does prevent in crisis, just making sure that there is a good match rather than a mismatch between what folks are doing for that individual and what the underlying condition is that's causing it. And so for those who have strong language ability and you're trying to figure out like what mental health condition is going on, well, you can talk to them or maybe use like a parent or teacher version of a questionnaire that typically is used for neurotypical individuals. But when the child or the adult has limited language, often those questionnaires that exist just fall through. They really weren't developed for folks with disabilities who have limited ways of expressing themselves. And when it comes down to it, we all communicate through our behavior patterns. And in this population who have limited language, they, very much, that is exclusively how they communicate is through their behavior patterns and to try to understand what they're trying to tell you through their behaviors. We'll be talking about this in a little bit, but I just want to do a shout out for sleep. In my world, sleep it's such a basic thing is getting adequate sleep. And yet for kids and adults with developmental disabilities, and certainly with Dravet, sleep can be quite disrupted. And in particular with Dravet, they might be having seizures. Or if they also have autism along with their Dravet, well, that also is often associated with sleep difficulties, being able to get your brain to turn off at the end of the day, as far as, putting the worries aside and that energy aside and letting your body rest so that the brain can restore through its own process. And so I always start with sleep. If an individual is not sleeping well, I want to understand why they're not sleeping well and think about what is it that can help facilitate that restorative sleep, because we all function better when we sleep. And certainly when you're talking about a child who lives with parents, if the child's not sleeping, neither are parents. And so certainly, and if you have a plan in place, it could be a great plan in regards to addressing behavior challenges. It's really hard to do when you're sleep deprived too, let alone for the child. Where I see kind of a roadblock with providers and being able to get beyond agitation and really focusing on what's causing the challenging behavior is that even though parents know everything they need to know to help that provider understand what's causing it, they may not realize what's relevant with the knowledge they have. And then even though the medical providers know how to treat the common causes of agitation in this population, they often don't have the time or even expertise to know what questions to ask to then figure out what they're treating so they can then treat that rather than just chasing agitation and trying to sedate, which I do not do. So parents are amazing translators, and I would also include in their professional caregivers. So I work with a lot of adults who no longer live with their parents, and their parents may or may not still be part of their lives. Many of them are, and it's great. And these individuals live more independently, or at least independent from their parents, but with the support of a professional caregiver. And the professional caregivers similarly have quite a wealth of knowledge about that individual to help me understand what's going on. And so as you can see just with this, I really see that parent or professional caregiver is truly being that translator between the person I'm taking care of and you know, the provider such as myself who is thinking about, well, what is there to treat? And then how can I best treat it safely and effectively? So I mentioned this tool that my team developed. It is freely available online, and I'll explain why that's the case. We have a lot of folks to thank for that. But it's branching logic, and it takes about 15 minutes, maybe 20, for parents to complete. And Aaron and Melissa have completed it on their child. What I mean by branching logic is that when you're asked a question and you respond to it, your next question is going to depend on what your answer just was. So in other words, there's no way one person is going to be asked all of the questions that are there. It's the questions are limited to what seems to be most relevant based on what your early responses are. So that's how we can kind of get it down to less of a burden. And then, like I said, the items are based on behavioral manifestations of diagnostic criteria that are established for common physical and psychiatric conditions. And we validated it with focus groups, and it's copyrighted by my institution. I'm a professor at the University of Utah. And like I said, it's free to parents and caregivers. The Autism Council of Utah up here is this amazing advocacy organization in our state. And they funded the development of this. And it was developed for parents. So you guys are the end users of this. And you're welcome to bring it in with your provider so that you can have a much richer kind of shared decision-making experience. If you were concerned about your child's behavior or their emotional experiences, it just provides so much more to that discussion, so the discussion can relate to what's going on and how to address it, as opposed to just trying to chase behavior challenges. So what this tool does is kind of like Candyland, like, here's all these things that can lead to agitation. And in my interviews, I'll just kind of go take parents through this long interview that takes about 45 minutes, asking all these questions. And finally, I kind of get close to then figuring out, okay, well, this is what's probably going on. So let's talk about what to do about it. And what the sources of distress does is it kind of just takes you right here, so and what's nice about it is it's not so much that you're now stuck going through all this by yourself. Like I said, usually this takes me 45 minutes when I'm doing an interview with a parent, but yet because of the skip logic, it takes about 15 or 20 minutes. At least that's the sense I get. Although Aaron and Melissa, you need to correct me on that when we talk, so I can get that feedback. So anyway, there's a report that is generated that is written for you. Of course, it doesn't diagnose. That is the role of the provider. Rather, it allows the provider to understand what the presentation of the stress is, like what I have circled under red here. And then it goes through that individual, your child's, what you described as their language ability, with the diagnoses you are aware of, what meds they're on. But then you go through their sleep history, their anxiety symptoms, their history of trauma, their mood, their tension, their thought process, like psychosis. And then I ask about medical questions. I think if I were to develop one especially for Dravet, I think I could think of some additional things I would change. I've learned a lot from you parents about Dravet. There's definitely nuances to that condition, as well as the treatment that's used for that condition that I've really appreciated understanding and learning from you guys over the last year. And then of course, dental issues, and then anything else that you want to let me know. So this is possible because of the Autism Council of Utah and then my institution, because apparently they own everything I make. So they copyrighted it, and that is just fine because I like my job. So we have the sources of distress. And then the Utah Department of Health and Human Services then contracted with my institution, which became even more complicated because we got this new name due to a very generous donation to my department. And in the registry of autism, which is a contract that we have here between the health department and my institution, they went ahead and put funding to support their own their own link. So they have a link that's publicly available on the Children with Special Healthcare Needs website, that anyone, like wherever you are, you don't need to be in Utah, you could go onto their Autism Services website and click on this link and then get an access to the survey. And then once you complete it, I will, oh gosh, look at that. Somehow I ended up, okay, there we go. Once you complete it, I will get a message that's automated from the HIPAA compliant server that houses the tool. And then what I'll do is I'll generate the report and send it to you. And if I see something in there that I think I can be helpful with, I can offer to speak with your provider. It's, you're not charged for it because there's no way of billing for it anyway. It's a service that the health department wants to provide, which I appreciate. And so that I can support your provider in understanding what's probably going on and how to help their decision-making as they work with you and your family on trying to make good choices in regards to addressing the behavior challenges or mood challenges that we see. And then they can reach out to me directly, and they'll have my cell phone number. And it's actually, we've done this now for a few years, and it's actually worked out quite well. So please feel free to email me with any questions about this particular tool. And now I would like to just kind of open this up to, I'm going to go ahead and unshare screen. There we go. Because now I'd like to talk with Melissa and Aaron about their experiences, and we can talk a little bit about the experiences of having a child with Dravet in regards to identifying underlying causes of distress.
I'm Erin Rioyo, and I am the Dravet Syndrome Foundation Family Network Liaison. But before all of that, I am mom to Eloise, who's 6, and Leonel, who's 9. And I'm married to my husband, Leo. Leonel is our child with Dravet syndrome. He's 8 now, and he was diagnosed just after his 2nd birthday.
Hello, excuse me. My name is Melissa O'Brien. I am parent, mom of 4. I have 4 boys, 19, 20, 6, and 9. Our 9-year-old son, Owen, has Dravet syndrome, and we live in Alaska, and I am a parent ambassador for Dravet syndrome as well, Dravet syndrome, DSF.
So it is so nice to have you two joining me today. I appreciate, Erin, you inviting me to speak to your families as part of the Dravet Syndrome Foundation. And as far as the sources of distress, I did want to just check in with you guys to see, do you recall, Erin, how long it took you to complete it?
I don't recall the exact time that it took, but I know that it wasn't a long drawn out thing. It went pretty quickly, especially the way you said that branching logic plays out. It kind of generated a prompt question from that, or it moved on to the other topic. And I can't say if it was exactly 15 minutes, if it was closer to 10 or maybe even 20, but I don't recall it being too burdensome compared to other questionnaires that I've filled out before.
I think when I think about it in comparison to other questionnaires that I know families fill out, like the stack of questions, I guess I could put it into context. How about you, Melissa? I know you completed it more recently. How long did it take you to complete it?
I would say it was probably right around 15 minutes. I would agree with Erin. It didn't feel like a giant amount of time. It was definitely a lot easier than some of the school paperwork we fill out that takes a long time. So, and I did appreciate the questions compounding to where if it wasn't relevant, it just moved on. Like, okay, my son doesn't have this issue, so it just asked different questions. So that was nice, the branches of logic.
That's great. Like I said, I developed this originally for parents of kids with autism spectrum. And when I say autism spectrum disorder, so it was developed for folks across this disability span as far as neurodevelopmental disabilities. the families of kids with autism are just this incredible powerhouse advocacy group that makes all things, change as need be. And so I found that momentum that they had really kind of supported the development of this tool. But when I speak about those parents of kids with autism, they'll refer, some of them refer to their children as having autism plus. So autism is a very broad range. And for this particular parent group, it's for kids and adults with autism that have autism and other pretty significant developmental concerns in addition to their autism that affect their ability to communicate their thoughts and feelings, and also make it harder for them to regulate themselves, like regulate sleep, regulate mood, regulate just their arousal states. As far as just what I learned from you guys, so I've learned a lot from you guys, particularly from you, Erin, and even from some parents who I had a chance to speak to as part of the foundation before even getting to meet you about Dravet. What I learned was how central the seizures are. And how, I should say, not only central the seizures are, but how central the need to treat the seizures are, because that is the most dangerous part of experiencing Dravet. With seizures, for you, Erin, how are things going with the seizures right now?
So his seizures are pretty much the same as the last time we spoke. And this has been probably consistent for at least the past year, if not a little longer. So we're definitely in we don't want to rock the boat. We don't have freedom. We have daytime seizure freedom, but that means that he has nocturnal seizures. So for at least the past year, maybe year and a half, he will have about every 10 days to 2 weeks. He cycles with nocturnal seizures where he'll have a couple of nocturnal seizures a day/night, lasting for a couple of days in a row. And I say day because he's still also on the weekends or on short school days or non-school days, he'll still nap. And so he has seizures during that time too. So he doesn't have the daytime, he doesn't have the awake seizures. So we're not running to try and catch him. So he is at least in a safe place when he seizes, but he's cycling that every couple of weeks.
I remember you telling me how you would see like a connection between his seizures and his behaviors and mood. Can you talk a little bit about that?
Yeah, so he sometimes you would think that, a seizure is building. We notice that a seizure is probably building up and he does get more agitated or his behaviors start to come out a little bit more. And we just kind of affectionately refer to it of just have a seizure already, just get it out of your system. And it seems to be that some of his better days at school occur after a seizure, where you think he might be really tired and exhausted from having those seizures early that morning. He's kind of got it out of his system and he's like almost ready to launch into a little bit of work, and he's a little more compliant and agreeable versus the times where you ask to do something and you might get a quick response of not just no, but throwing something or hitting at something. So it is this weird kind of buildup that seems to happen in a system.
And with the seizures and how that affects mood, with Dravet, because of how aggressive you need to be to get on top of the seizures, which is the life-threatening condition that children with Dravet experience, you will often use, you could end up using some medications that may affect other things, but the priority is the priority, and the priority is the seizures. And so, as a psychiatrist and pediatrician, talking with families of kids with Dravet, I think recognizing just that fundamental component that there's things that you can change here and there's things that you just do not touch here. And even if you have a child like Leo now whose seizure are still there, but they're not where they had been, years beforehand. And we're all very grateful for that. But you just don't walk the boat on that. And so recognizing that sometimes the medicines that are used, particularly for Dravet, that can help with seizures, may affect mood, may affect anxiety, and yet are life sustaining and life necessary. One thing that you mentioned too is just how sometimes it seems like he'll tire out, and then when he tires out, you'll see more challenges, with his decisions and with his behaviors. And I think you were telling me about that at school too. Like you wonder at school how, because he has so much ability. Lionel has a lot of ability, and how sometimes it probably does get exhausting to be trying to tap into that ability all day long. And towards the end, he could find himself just having a hard time just managing how he feels as he wears out. With his sleep, what are some of the things that you've done to try to help foster good sleep? Because I know just when I talked to you, you recognized right away. You've known as his parent that sleep is always such a critical part of his wellness.
He, for the longest time, he has had sleep issues. And I say that even before Dravet, in that he was somebody who always wanted to be held to sleep, and he was my first child and I was a new parent. And so we did a lot of that. So he is a very bonded sleeper. And even now, if he sleeps in our bed with us, he's an extremely cuddly little guy. So, sometimes I wasn't sure how much great sleep he was getting if he wasn't on his own. Fast forward with his Dravet diagnosis and the seizures, and then it started to have behaviors that would impact his sleep, either of not wanting to go to bed or just not being able to fall asleep. Now he has incredible sleep hygiene in terms of he likes to go to bed. He likes to have his little story and he closes his eyes. We do the sound machine, we do the blackouts, and he doesn't have any problem with that. Unfortunately, he has a mild sleep apnea. And so he is prescribed a CPAP machine. Over the course of the year, there was a global recall on his CPAP. So we had just started getting to use the CPAP. He was starting to get used to it. And then there was a huge global recall. So he's not had use of that CPAP. Again, it's mild. I can't really speak to the type of apnea that he has because there was a pandemic since all of that diagnosis. So we all just, we've been trying to get by. Thankfully, we have just, as of last week, received a new machine. So just on my to-do list is to get another sleep study scheduled. But it is definitely something that we wondered about and were curious about following his diagnosis. And I just wonder if I would have had access to something like the sources of distress, if we would have come to that conclusion a little bit faster into some of that, behind the agitation and how it impacts how it's impacted by that sleep.
I think that's in the report, so parents get, report that just describes it. And as I listen, it starts with sleep. And I remember when I was talking to you first about the report, as I think about it, so it doesn't interpret the report. What it does is it describes what you see and what you observe, so that a provider like me can go through and see all the pertinent positives, like what issues are coming up underneath each of the different categories. But it doesn't, it's not at the point where it translates it into, you have this disorder, you have this concern or this concern. So I remember when I first talked with you, we talked about the report. I don't know if that had jumped out, but as we talked more and more, it became, clear to me as a provider. And then for you, it started like clicking and you're like, oh yeah, I totally know what it's like to not be able to sleep well at night, and thinking, retrospectively, and how he's always, had been a very cuddly sleeper, and realizing for Leah now that is something. And so I think like just something I learned from that experience in talking with you is thinking about, as this tool evolves over time, and as the report evolves, and how to be able to help parents know what seems to be lighting up, so to speak, as far as this looks like it's a concern and this looks like it's a concern. And still yet not stepping on your provider's toes and saying you should take care of this or this. I have to think about how to do that and try to ensure that it doesn't feel like it's being kind of thrown on the providers, but more helping the parents kind of consider what may need to be prioritized as far as what could be leading to all this other stuff. And then talking with a provider who knows your child and can, get more of a history to clarify that. Did you have a chance to talk to your provider after we had spoken about sleep? Or did you just find that knowing that you just needed to, circle back to the CPAP machine was kind of on your next to do?
We haven't circled back with our provider since I've done the sources of distress. We are scheduled in October for that follow-up. So I am going to be sharing with that just as a, sharing what we've learned as far as with Lionel, but also so that he maybe can get prepared since he works with many Dravet families. Maybe he'll start getting more of those reports.
And I can tell you just my experience as a provider is whether it's a parent who kind of pulls them in or, so in my world, as I'm working with kids with autism, and I do know that parents of children with Dravet do have more experience with autism than parents of other children with other types of seizure disorders. But as you know, those with autism, when they have challenges, they really can be quite amplified and quite significant. And so as a result, sometimes providers would reach out to me directly and ask for a link because they've heard of it. Sometimes the state will kind of get me involved to try to support a family and they're dealing with a difficult situation. And so the provider inadvertently gets pulled into this. It's just like, hi, I'm Dr. Bilder. I'm just here to help. And I have some suggestions for you. But once we, and usually it's this really, big, really very difficult situation. And when the ship's righted, because that's what I do is I just kind of keep on righting the ship, where I work. And the provider has a chance to see, wow, a situation that probably to him may have felt a bit hopeless, or, people can get really nihilistic, when they're working with kids with developmental disabilities. Sometimes they feel like it's never going to get any better. But realize, no, it really does. It really does get better. Kids, once you figure out what's going on, you can really help them and help them feel better and help them make better choices. They'll then think about their other patients that they take care of, and hey, maybe this might be helpful for this too. And so there's a good handful of providers out there who we've since developed, quite a great working relationship. And now they find themselves attracting more and more patients with these challenges because they seem more comfortable and confident with it. So yeah, I'd be happy to get to know your provider. And so Melissa, with Owen, so we just got a chance to meet Melissa and I yesterday, and you got to tell me a bit about Owen. What were your thoughts as we talked about the report and some of the things that you had described in the report to help me understand, Owen and his ability and his challenges?
Yeah, I think for me, the biggest thing was how helpful it would be for his team, his school team, his care team, kind of compiling all of that. Because we, as parents of Dravet, we know all of those things work together, but that's the biggest thing that we struggle with is making sure, his school team knows that the medication side effects and quality of life and balancing the seizures and all of that. And so something like that, just seeing it all in that way and having it as a tool to be able to share with his team, I think would be really beneficial to families of kids with Dravet.
I remember when we talked about Owen, I was impressed to see how well, so as a parent, you've been very conscientious of his school environment and trying to find that right fit where he had the support he needed to succeed and to shine. I think if you would have completed this, when did you move? Was it last year that Owen moved to his new school, or was it the summer that he moved to his new school?
It was 2 years ago. So so he's been at this school. This is his second year there. So, and I think, as parents of kids with Dravet, I think we'll all agree that our kids are very naughty in a good way, but they are so darn lovable. And so we all know the difference between agitation and their behavior, but trying to get their care team to understand, that this is abnormal and this may be the precursor to a seizure and those kind of things. And it sometimes does take a little bit of work to find that right fit for their school team.
And so if you were to have completed the source of distress, which really takes, parents through just a list of questions about their behaviors, their experiences in different situations, their expressions of anxiety and mood. Do you think it would have looked different if you had completed it when he was attending his previous school?
I'm not sure. I think for us, we're in a unique situation where we're at. We live on an island, and there's one district. And so for us, it just has been just kind of just finding that right fit all around. So we've adjusted with his great team at his previous school. Even we tried modified day and we tried different things, and for him, it just wasn't the right time. But I think I mentioned yesterday as well, this seems to be the year that everything is clicking for him. And so we're capitalizing on it. We're like, this is the right school. This is the right time for him. Everything's just working perfectly. So I definitely don't think having a report would have hurt in any way, because it's just, like I said, one more tool that we can kind of put in our bag and everything all together to show them like, hey, this is who he is. So
and as far as and so kind of that clicking, so for kids with Dravet, what I've learned from parents like you is, kids can be progressing, and then, seizures could become more problematic. And then you see that they seem to lose some ability or lose, some functioning. And then it's really kind of playing catch up. And I could imagine that schools, if they're not as familiar with Dravet as, your organization is, as kids are trying to catch up, or when they feel behind and they're just not able to do what they realize they have been doing, that can lead to frustration, and it can lead to behaviors. And if schools don't recognize where this is all starting, which is really with the seizures and the ability that, can be affected by those seizures, that they might find themselves attributing it as like, oh, that's behavioral, as if it's not related to a medical condition. And I think kind of what you're saying, Melissa, is that as a parent of a child with Dravet, you can't separate the two. And I like everything's behavioral. So when I get involved in a situation, and, because I'm the psychiatrist, I come with the psychiatrist hat, I'm also the pediatrician, but I'm coming with a medical hat. And I'm looking at like the medical management of something, and then of course we have our behaviorists who are very helpful, who look at the behavior patterns. And I will sometimes approach a situation and be told, oh, we don't really need your help because this is just behavioral. And yet in reality, it's like, everything's behavioral. And let's take a look at the behavioral component of this that might be suggesting that, a child is overwhelmed, or a child isn't feeling good, or a child's anxiety is really just being taken to the limit, or a child's, sleep is not restorative enough. Or they're not feeling well physically. Like what part of this behavioral it is, could be assisted medically, as well as looking at the choices they make and the consequences. And so I think in talking with you and hearing your experiences of things being attributed to behavioral, it's like, well, it's not that there isn't behavioral manifestations. It's like, well, you kind of go back to a little bit to understand, well, what precipitates those behaviors, and how can we make that better for the child. So as I know we're getting close to the end of time. Do either of you two have any questions about the tool or the curbside consults that I do to help providers to take care of, children as yours, just be able to be better prepared at addressing, some of the challenges that come up from a mood or anxiety or behavioral perspective?
It's not so much a question. It's just kind of restating like how nice it was to kind of pull all the information together. because so many times I would maybe have something in the back of my mind and wondering, for example, Leonel would cough with thin liquids at, kind of at an earlier age. And that stood out to me because I'm a speech pathologist. And while I'm not trained in swallowing disorders, I have a little bit of knowledge in that. And most other families are maybe not have a speech pathologist in their home. So they might not know that that's a flag. But just knowing that in terms of, there were the questions about the eating or the drinking and that. And for a while, Leonel was experiencing these chronic sinus infections. And so I felt like we were really on our own to try and figure out, is it an allergy? Is it something related to swallowing? Is it something related to sleep? Is it something related to ear, nose, and throat? And we felt a little bit alone in having to decipher what some of those things meant and what decisions we'd have to make or other providers we'd have to call. So of course, once we started like sitting down and gathering our thoughts with all of that, we were able to talk to his providers about it. I think it just would have been really helpful to have a tool like this to help really organize all those different pieces. A big side effect of medications, particularly one of the medications he's on, is as an appetite suppressant. And so he has some feeding challenges as well, but is it a sensory component? Is he just not hungry? Is it, so we do have all of those questions, but all of those also contribute to some of that behavior and agitation. I know that if I'm not eating, whether or not I'm hungry or not, or maybe my appetite's a little suppressed, it still affects my behavior. And so I can recognize, oh, I need to stop and I need to eat something. And not necessarily. So again, I just really looked at it as a tool to be able to, like, a really great tool to kind of put it all into one place, so that we have to do less of the guessing and trying to figure things out. So I thought it was really helpful in that aspect. And, and I know that I'm not alone in having to do all that guessing and framework, because I see posts from our families of so many things. Could it be this? Could it be that? Could it? And so, I don't know how many families will go on to use this tool, but it particularly those, with children where you're really trying to figure out some of these, what's behind some of those behaviors, and you might not get the exact answer, or you may get comments from other families that this is what it was for us. But I really, think that it was a really nice tool to be able to figure some of those pieces out, and would have been helpful earlier on.
And well, thank you. And one of the things you just mentioned, so I'm a disorganized person by nature. So I compensate by being very organized and trying to be as structured as possible. So, you could see that with the tool, like, it's organized for me. Like, as I was saying, it would take me 45 minutes to make my way through Candyland, but the tool like makes it work for everyone for 15 or 20 minutes. And just listening to you talk about that, as I think about the people I take care of, and I think children with Dravet are fall right in. It's like it's not just one thing, and I think, but my hope with the tool is to help people be comfortable with that. It's like, yeah, sleep's an issue, and the medicine's an issue, and on top of that, the medicine affects appetite, and that's potentially going to affect how you feel, or it might even affect the experience of anxiety. And yet, that medicine, that cannot be changed. That is a lifesaver for this child. So let's think about this. Let's think about what other pieces of this could be adjusted, whether it's in the environment, whether it's addressing sleep, like what you did, and looking at other things that could be affecting sleep and how to make that better, or how to optimize how he eats when you can get before he probably doses, or but kind of, I think having that roadmap of looking at, okay, this is what the landscape looks like, and so with this landscape, with multiple things going on, what about this is lowest hanging fruit and likely to be most helpful, and not going to create issues for these other things that are more important, that are the priority. And so like for your kids with Dravet or other kids that I work with that have other, tuberous sclerosis or Down syndrome or other genetic conditions, or maybe born prematurely, it's not just one thing, but it's still, there's still a direction to go in. It just helps to have kind of an organized approach, and understand, just as you had said, when I talked to you, you said, yeah, that the medicine affects his appetite, but gee, it's had this huge impact on seizures. So we're definitely not going back. And then, but we need to think about how do we help him with his appetite, recognizing that this is something which is necessary, and how do we accommodate that? And I think having that flexibility and always being willing to kind of go back to the drawing board. Okay, well, if this didn't work, let's think about going in this direction and not getting too stuck in one direction. We're not willing to go back and kind of revisit the basis of your hypothesis to begin with, because maybe it's not working well right now because a new issue came up. So kind of having that flexibility as you move forward.
I'm curious, and I think some of our attendees will be curious, what's the youngest age that you would suggest for going through the sources of distress? And is there an oldest age, or how, because we do have families who are joining who have newly diagnosed 6-month-old babies. This might not be the place where they start right away, but when would they start to consider this? And we have families who have young adults in our community.
So as far as how young, outside of Dravet, this has been completed in children as young as 3.5 or 4. It was originally developed. So this is kind of a second to third iteration that's currently in use, and this iteration has been in use since 2019. Well, actually, the most recent iteration has been in use since 2020, December 2020. So initially, when it was developed for adolescents, like through adulthood. I don't know the oldest person who has completed this, but as I think about patients, I've had patients in their 80s before, who actually were very, very calm, but I could easily think of patients in their 50s or 60s. Who may struggle with distress, and this would be very helpful. So I don't see an upper age limit. The lower age limit, I would say about 3.5 or 4 years of age. And when I say that, I'm not talking about a cognitive age. This wasn't really intended to coincide with cognitive ages. It was intended to coincide with physiologic ages, like chronologic ages. And I think the indication, because it is broad and it definitely looks at medical things as well as mental health issues. I wouldn't be, I wonder what it would look like if a parent of a 2.5-year-old completed it. The trigger for the tool is that the child or the adult needs to be experiencing distress. So it's not intended to be a way of identifying like the frequency of this problem or that problem in the general population of children with this condition or that. Like it wasn't intended for that. It was intended in the context of a child experiencing distress. And when I refer to distress, I mean, something's off, something's different. You can't figure out what it is, maybe, or maybe you can, but they're not sleeping as well, or they're agitated or irritable, or having changes in their appetite. Or, one parent, just had more fixation. I can't think if I've seen this among your children with Dravet, but in other children that, particularly those who have autism, will find themselves having self-interest behavior. And that would be their manifestation of distress. Like something's off. You've got to figure out what's distressing them. So rather than think of it so much as an age, I would say it's if they have gotten to the point where they will to manifest an experience of distress, then something's off. Them well enough to know something's off, and it's unclear what it is. They are absolutely welcome to use it. And see if this could be helpful for them. As far as the later ages, it's funny you brought this up. I was recently, my medical student who works with me was recently presenting our data on the first 250 individuals for whom this has been completed. And one of the faculty from our geriatrics clinic came by. So we were presenting it at a mental health day, the University of Utah Mental Health Day. And one of the doctors at the geriatrics clinic stopped by and said, hey, this actually could be really helpful for some of my patients who have difficulty letting me know what's going on, but we know something's off. We're going to be meeting with them, I think starting probably in a couple of weeks. Not that I'm going to have their patients fill this out, but I'm going to start, I want to talk to them more and understand better what they see, because I think I can adapt this tool for their population. So for what they are always looking at and for what they're concerned about, but have a harder time eliciting from the individual or from their caregivers, I feel like this tool can be morphed, so to speak, to support their efforts as well and understanding their population, which also can struggle with expressing what's going on and what their challenges are. So to be continued on that, and maybe somewhat relevant to this, because this tool could certainly be used into the geriatric ages. Like I said, I'm gonna have to look at my data and take a look and see what is the oldest for whom it's been completed. Oh, and as a result of that, so in the newest version that was started in the in the summer of 2020, to really pull it down into the younger ages as well as the older ages, I was able to include a component on menstruation, because for females with neurodevelopmental disabilities, menstruation can be hard for them, whether it's the fear itself of what's going on and not understanding it, the physical discomfort, the emotions, because you feel different each week, as a woman when you're cycling. There's a lot of different components to it. And so that was put in there in a way that it only gets triggered if it's about a biological female, because to be sensitive to gender diversity. So for someone with a biological female who is of reproductive age, it will trigger into just some questions about menstruation, just to understand whether that may be a component of what's going on too. So just trying to capture that, the broader context of your physical development as well as your emotional development. So.
I think that's a really great observation, because I know in our community, just seeing some posts about girls of that particular age group and that subset, and same with boys of when they start going through puberty. So some parents might start to notice and look at as this tool if they suddenly are experiencing something else that's off, and considering what puberty is doing now into their whole mix.
And mentioning that with puberty, like for example, for boys or girls, when I'm working with families before their child hits puberty, I know they're approaching with apprehension, and I can certainly appreciate that. My general experience in having worked over, almost 2 decades now, is I don't find that we have to reassess our goals as far as the mood control and the anxiety control and the behavioral control. I just find that we sometimes have to be more aggressive in how we manage it, but we haven't had to change our expectations in that regard. So I could definitely I get the need to be apprehensive, because it's a real thing, and yet it doesn't have to change where you're hoping to where you're hoping to keep that baseline, but you may need to step up a bit on how you're addressing those underlying concerns, or new concerns can emerge, certainly with puberty, certainly in the mental health component, to recognize and then adequately address that, so you can maintain that baseline that you've been working towards all along.
Really great points. Melissa, did you have anything else you wanted to add?
I do. I just want to say, I think that one of the biggest things that we talk about in the Dravet community is getting people to understand that it's more than just seizures. And so the importance of something like this, epilepsy or Dravet it falls under other health impairments on an IEP. And so you think about getting your child services in the district, and they just look at it as epilepsy, and so we as parents of kids with Dravet know there's so much more with Dravet than just seizures. There's behavior that some, autism dual diagnosis is not uncommon. And so something like this, having a tool like this to be able to bring into that school classroom and that team meeting, just to show the right supports are in place, I think is going to be it will be really helpful for our kids to get the supports and the accommodations that they need if they do need special services in school. And most of our children do. So it was definitely worth the time to do for me to have it all in one compiled space, for sure. So it's more than just seizures.
It certainly is. And I learned that more and more as I talk to you guys. So the link, so I will make sure, Erin, you may already have it, but I'll make sure you have the website address. So to the Autism Services website that's hosted through the Bureau of Children's Special Healthcare Needs, because that's where the link is posted. And like I said, anyone who wants can access it. You don't need to live in Utah. If it were help someone, they're more than happy to, and you certainly don't need to just have autism. It's just, like I said, that's where a lot of the advocacy was. So that's where it found its place, but it is intended to be relevant across the spectrum of disabilities. So. Well, thank you guys for participating in this with me. I really appreciate it.
Well, we appreciate you. Thank you so much.
Thank you so much, Dr. Bilder. This is just such an amazing tool, and we're so glad that you could be here today to share it with our patient community. Before we dive into some of the questions that came in, I did want to respond to the person who asked if these recordings would be able to access later. Yes, they will. We're going to house them on this portal for approximately 30 days, and then they'll migrate to our main site. So you'll be able to share them with whoever you would like so they can learn a little bit more as well. So we did have a few questions that actually came in before our session. So I'm going to start with those before I dive into the ones that came in through the chat. Dr. Bilder, the first one was, one of our parents wanted to know, which providers do you typically communicate with? Is it neurologists and epileptologists, pediatricians, or others?
Oh, so like all of the above. When I'm working with a child with a seizure disorder, it often is the neurologist, but ironically, it's on the neurology team, but it's actually the physician's assistants who work with neurologists who I find particularly easy to work with. And here in Utah, like in the adult population in particular, they don't practice independently from a group, but yet they're often the ones who are in charge of the vagal nerve stimulators. Like they do a lot on their own as they work with the specialists. So like the nurse practitioners or physician's assistants. When neurologists get me on board, often it will then kind of get delegated to working with the mid-level providers, which works really well with me. With children without syndromes like Dravet, who may have seizures, but not the type of syndromic epilepsy that your families experience, I do work with a lot of primary care providers and a lot of pediatricians, since for those individuals, those are the folks who are presented with these behavioral concerns. These are the pediatricians, nurse practitioners, physician's assistants, who the parents go to when they are having emotional and behavioral problems with their child. It doesn't go directly to the neurologist. So it's really a blend of both, and I would say it relates a lot to the seizure severity.
And have you found any of those providers are resistant to the tool just because they don't understand it?
So the neurologists aren't, or the physician's assistants with neurology or the neurologist, they're not resistant, but they're the ones who are reaching out to me. So this tool is used pretty extensively here in Utah. So we already have this relationship. Often these neurologists had been contacting me for years before the tool was developed. The tool in part was developed with them in mind, in that when they're reaching out to me and asking how can I help them understand the behavioral issues or help them address the emotional behavior issues associated with it, I realized as I was talking to these providers that they didn't have the information they needed to help me figure out what's going on so that I can offer recommendations to them. And so what I realized that they needed a tool to be able to get so that we can collect this information from the families who know all this information, so that I can then speak to them about what parents describe, so that when I'm offering recommendations, it's very specific to what condition appears to be present versus just the non-specific, moodiness or disruptive behavior.
That's fantastic.
I could tell you who I found resistant. Is sometimes the psychiatrist. I am a psychiatrist as well as a pediatrician. I think my personality is probably very much like a child psychiatrist, which I'm a child psychiatrist and a general psychiatrist and pediatrician. Child psychiatrist personalities are kind of a combination of like a pediatrician and a psychiatrist. I think there's something about the draw towards children and families, which lends to that more, partnership with others, working together. But I do find that sometimes they'll have, pushback. Well, I don't think about it this way. I think about it just as disruptive behavior. And so I would have to say my biggest pushback that I get from working with other providers is ironically, the psychiatrist who you would think would be most open to considering these underlying conditions besides just the behavior that they're facing.
But that's good to hear that most providers are open, because I feel like that would give our parents an opportunity, if they were dealing with someone who was unsure just because they were unfamiliar, that they know that they could possibly ask another provider they work with and perhaps get a different response.
Yes.
And this question came in via the chat, and it kind of ties into this. One of our parents wanted to know, how could this report be used to help guide in the IEP process? And I would be curious, have you ever had a parent that's come back to you and said that they've used it in that way?
I haven't had a parent come back and say they've used with the IEP process. I recently spoke to educators as part of something we have here in Utah that's sponsored by the Utah State Board of Education called the Transition Institute. And I was asked to speak there, and the individuals I was speaking to were teachers and educators specifically for students who are transitioning, special education teachers for transition age students. And so, and this was back in May. So actually, I'm pretty sure one of the reports is going to be used as part of an IEP coming up. So I'm just kind of entering into that aspect of this, and that really came to light because a group of educators became aware of this tool, and I subsequently got invited to speak at this group, and now they're interested. The tricky thing with education that you guys may or may not be aware of is if they identify a mental health concern, they're expected to pay for the costs of managing that mental health concern. And as a result, overall, I think the schools are very reluctant to be the ones to identify this, because they're afraid, at least in our state, of then having the responsibility of paying for that cost. And so the way we're talking about it here in Utah is working with the Utah Parent Center, which is a parent advocacy group, so that when the schools now see an issue that they think would benefit from this tool, they're referring to the Utah Parent Center, so the Utah Parent Center can just give them general resources. And among those would be this tool. And in that way, their connection to this tool was separate than the school, so that the school wasn't responsible for paying for it. And yet the school, recognizing these issues, are able to get these kids to the right place, so to speak, to have these concerns addressed.
I think that's really a good solution, because I had not thought about it being used for IEPs, but I really see where the value could be. We frequently, at DSF get requests from educators who are just trying to figure out the best ways to serve these patients. And so I think having kind of the skeleton guideline would be really useful for them.
Well, and I think so, and you are a parent advocacy group. And so the role you can play there is is for schools to realize they can reach out to you, or that they can refer parents to you, and then you can let them know about this tool. And then that way, the parents' access to this tool wasn't through the schools, but yet can still inform the educational environment and their understanding of the student without feeling the obligation or the financial obligation to then pay for mental health treatment. Right. Which, at least in my state, they don't have the funding to do that. And so they're very weary.
Yeah. This next question comes from Austin. She said, should each parent or even primary caregivers fill out and complete the sources of distress separately or complete it together? And then she said, I found that sources of aggravation are different with different caregivers, which I think is a really good point.
Yeah, that is a really good point. So what I've done, determining the circumstances is, so I've seen it both. I've seen parents together complete it, and then I've seen them complete it separately. When I've seen them complete it separately, they're separate households. So the parents are not living in the same household. I find it really helpful to get information from multiple sources. So typically what that looks like is that for a child who is not living in the family home because of the severity of their disability, or maybe they're adults, and so they, like their adult siblings without disability, they have an opportunity to live in a setting where they have supports, but it's not in their parent home. It is really helpful to get like the professional caregiver's response as well as the parent's response, because it's very helpful to see the broader picture of what's going on. As far as when two parents are in the same household, I think I like it when they fill it out together. I do, because I think that when they talk about these different issues, it allows them to discuss more about these concerns with the context of, oh, this looks like this is related to anxiety. Well, I've seen this. And so I think because it helps them process it together as parents, as that parent, partnership and unit in the context of understanding the behaviors of the child. So I think there's really value to that for the parent's experience.
Yeah, I would agree, because I think my husband and I sometimes come at our son's care very differently. And so I think it would be beneficial to have both of those perspectives when you were doing this. We did have another parent who'd written in with a very similar question to the last one, but she did ask one thing that I thought was interesting, is she said, do you ever have medical providers complete the sources of distress for these patients?
Not medical providers. So I haven't had medical providers do so, because the questions that are being asked are intended for those who live with the child or know the child very well over a long period of time, because I'm asking about sleep patterns, I'm asking about behavior patterns that would be outside the environment of the clinical office. What I have had, though, and this really reflects, I think, the child or adult's circumstances more than anything, is I've had case managers for our state Department of Division of Family, Division of Services for Children and Families, so DCFS. So if a child has a trauma history, is in protective custody, I have had like a DCSF caseworker complete it. What that reflected was that reflected that was the person in that child's life who knew this child better than anyone. And I think that's reflecting the circumstance that child is in. I've not seen a medical provider. I don't think I've ever seen a medical provider complete it. They just wouldn't have the information that the caregiver and parent would need.
I would agree, because I feel like, and I think all of us as parents would say the same thing. You go in and you see that physician for an hour, and so they just have no idea what goes on the other 23 hours of every day, and wouldn't be able to perhaps fill in the blanks as well as a parent could.
And they don't know what to ask, So I think so even if you had a half hour with your medical provider, they won't necessarily know what questions to ask you that will then be prompted in the survey that would help me understand what's going on.
Sure. Erin, I'm going to put you on the spot a little bit. Was there anything in particular that was a big revelation or a big takeaway for you, or anything else that you wanted to ask Dr. Bilder now that you've had time to sit with this information that you received?
Not that I want to ask Dr. Bilder, but I just want to reiterate, it is really great to kind of streamline all this information to share with providers. And we're going to be doing that at our upcoming, we have our neurology appointment coming up. I have still on my to-do list for our sleep neurologist to do. So we're going to be sharing that, a lot of that with her as well. And I wouldn't say that I used it to guide in our IEP process, but it certainly helped me feel like an even better advocate for reminding our school team of these issues, and just being able to put it all together. And they were really receptive to just hearing another, it's not coming from our direct neurologist, but they did, I did share with the way the report, kind of laid some things out, and it was an additional aha, and they express their appreciation, which is always great to get some appreciation back from your school team. So that really, it helps me just build some more advocacy.
That's great. So for those who are watching this on demand, Erin did tuck in the information, the link on how to access more information on this tool, as well as Dr. Bilder's contact information. If you miss it somehow and you need to get it, you can always reach out to us at DSF. And again, we would just really like to thank you, Dr. Bilder. We really appreciate you making the time, as well as answering these questions from our community. So thank you for joining us.
You're welcome, and thank you so much for inviting me. I've learned so much about Dravet from you, from Erin, from other parents that I've had a chance to connect to as a result of your work. So I'm looking forward to working with additional kids and their families to help them in this process.
Wonderful, thank you.